All right. So with our case here, we gave you this patient, Joanne, this 56-year-old woman, blood pressure's high. She's on a calcium channel blocker and an angiotensin receptor blocker, a long-acting one, olmesartan, but she's still high. So what might be your next steps in someone like this? I mean, because now we're starting to think like, do we need to add another agent? What else should we do here to troubleshoot this?
Yeah, so she hasn't yet proven herself as resistant hypertensive because she isn't hypertensive on 3 antihypertensive medications. I can tell you by her current blood pressures, I think it's going to be unlikely we're going to get her to where she needs to be with one more agent, but we have to go through those motions before we go crazy because she might just be really volume sensitive and missing that diuretic. So, in somebody like her, I would have a very low threshold to put her on a 3 drug fixed dose combination, keep her life simple. So we can do olmesartan, amlodipine, HCTZ, keep her on the same 2 other drugs, and I would start there and see how she does. Because some people really do surprise you with how diuretic sensitive they are. I think that thiazide diuretics used to get this bad rap of just not being great antihypertensive drugs, and it's not true. They can be incredibly effective. It just depends on who you treat with them, because different folks are more responsive to some agents than others.
And you mentioned a triple fixed dose combination.
Yeah.
I don't have anyone on this right now. I'm not sure if Paul does. It sounds like it'd be expensive, but is it expensive?
It's often covered by Medicare or Medicaid, depending on what year it is. They usually will cover and which version of it they have, but they'll usually cover a triple pill fixed dose combinations as well as a lot of insurances. And if not, it might require a PA, a prior authorization, but it's usually very quick. It's not like going through SGLT2 inhibitor prior authorization territory. It's usually just a very quick note saying, justifying why, and it gets approved. I have not had trouble in the last year or two getting one of these approved because they are so inexpensive and they're available for very, very low prices if you go through some of these like cost plus drugs or pharmacy type pharmacies. So I think insurers are becoming wise to that and willing to cover them
Mhm.
typically. There are a couple of triple pill fixed dose combinations of first line agents that I'm aware of. There's the olmesartan, amlodipine, hydrochlorothiazide fixed dose combination, and then there's a valsartan, amlodipine, hydrochlorothiazide fixed dose combination. I tend to go towards the olmesartan one a bit more because it is a little more potent than valsartan. There's some folks argue that there's some older literature suggesting it might not be, but the literature that I tend to ascribe to shows that olmesartan is just a bit more potent. So that's been my preference. But if it's not covered, then I'd say go for the valsartan. You'll get a similar benefit. You're sitting there sort of splitting hairs at the differences.
So Jordy, the patient we gave you here, she's 56. Her blood pressure are in the 150s to 160s over like the mid 90s, and she's on a calcium channel blocker and an angiotensin receptor blocker. If we add that third agent, the thiazide diuretic, how much blood pressure lowering would you expect we might get from that?
Yeah, so it's a great question. On average, from a third agent and somebody who's like this, from my experience and seeing how high her blood pressures are, you do see greater blood pressure lowering the higher your blood pressures are to start with. So that's the reassuring thing, is that we know we'll get more bang for our buck with adding this agent. But I don't think we're going to get more than 10 millimeters of mercury from a thiazide diuretic. I think that's great. I think it's important to add, that's something that we tend to expect when we're adding a new agent, is somewhere in the range of 5 to 15 millimeter mercury improvement. So I tend to sort of have my expectations smack in the middle of that. Sometimes you'll see less because you'll only get that 5 millimeter mercury improvement. For a drug to be approved by the FDA as a new antihypertensive agent, typically the requirement is a minimum of a 4 millimeter mercury improvement by ambulatory blood pressure monitoring, which usually equates to somewhere close to around 8 to 10 millimeter mercury improvement in clinic blood pressure, depending on how and who is measured. Which we can talk about in a little bit. But it's really interesting because the only agent that we really see something quite different than that with is when you add spironolactone as your fourth agent. There are meta-analyses that show that when your fourth agent is now spironolactone that you're adding to those 3 first-line antihypertensive medications, that you get on average a 20 millimeter mercury over 9 millimeter mercury decline in blood pressure in several studies. And so it's just this enormous enormous added bang for your buck. And I think it just says a lot about what a common mechanism of resistant hypertension is what we talked about, is this upregulation of RAS that's just not quite getting hit enough by those first line antihypertensives in some patients, and this just knocks it out. So that's part of why I think we see so much benefit. Also, because I think a lot of these folks have underdiagnosed primary aldosteronism, which we can get to. So I strongly urge folks to add that MRA when you're ready.